Thank you very much for the kind introduction. As Mike said, my name is Toral Gathani. I'm a consultant surgeon in the trust, and I have dutifully been going for my 2 weekly swabs since the pandemic started, and have been vaccinated and have had my antibodies tested. I'm also a clinical epidemiologist, and I first came to Oxford almost 20 years ago now to do my MD in the cancer epidemiology unit, and have maintained an interest in that since, and I was appointed a senior fellow in the summer of 2019. So what I'm going to do is start by just giving a little bit of background. I'm not going to presume that people know too much about how we diagnose and treat breast cancer in this country. So I'm just going to give a couple of slides of background that I think is relevant. So here we've got some data on incidences in the UK. The pie chart on the left is for both men and women, and on the right for women alone. And we can see that we've got about 460,000 incident cancers in the UK, and 4 disease sites will account for almost 50% of the cancer incidence: prostate, breast, bowel, and lung. And then amongst women, breast, lung, and bowel will account for about 1/3 of the cancer incidence, about half of the cancer incidence each year, and breast is about 1 in 4 of the cancers that are diagnosed in women. And so when people started talking about the impact of COVID on cancer services, clearly what was going to happen to breast would be of interest. And just to give you an idea of the distribution of age at diagnosis for the disease, so about 1/3 of breast cancer actually occurs in women over the age of 70. And again, this in the context of the pandemic was of interest, given that this was the group that were considered, identified very early on as being vulnerable. And then you have this bulge in the middle of women in age between 50 to 70 who are diagnosed through screening and through symptomatic presentation. I'm going to talk about that in a bit. And only about 20% of breast cancer occurs in women under the age of 50. So you can see there what the age distribution is, and then potentially what the impact of that could be, given how the pandemic had was closely associated with age as well. And then my third slide, by way of background, is just to talk a little bit about the routes to diagnosis and why this is important. So breast cancer is a disease that presents in a calm manner, if you like. So bowel cancers and intra-abdominal cancers can present as emergencies, and that's quite a common route to diagnosis. Breast is very unusually presents as an emergency, and when it does, it's usually due to metastatic disease causing some kind of symptom. But more commonly, far more commonly, breast cancer presents through 2 main routes. And the first route is through screening. So screening is all about early detection. It's about picking up cancer before a patient has developed a symptom. And the service is provided for a target population, and in the UK this is women aged 50 to 70 who are routinely invited every 3 years to present for a mammogram at a local screening centre. The mode in which screening is going to be offered is changing currently, and it's moving towards a system of open invitation, so people will be told that they can ring and make an appointment, as opposed to the system we have now where people are given a date and a time to turn up, and there's various reasons why that has happened. And as I said, it's for women aged 50 to 70. And then we also diagnose breast cancer as early as we possibly can. And this is about symptomatic presentation. So what happens here is that women will have a symptom to which they will present most commonly to a primary healthcare practitioner, and then be referred into secondary healthcare for assessment. And breast is slightly different to other tumour sites in that GPs can choose to refer patients in urgently or non-urgently, depending on their index of suspicion. But in secondary care, it actually makes very little difference to us, because we have to assess all of the women who are referred to us within 2 weeks of getting the GP referral. So essentially you have these three routes. So you have the 2-week wait, which is a suspected urgent cancer diagnosis from the GP, a symptomatic referral from the GP for assessment of symptoms, but they may not think that will result in a cancer diagnosis necessarily. And then the third route through the screening program. And just to give you an idea of the numbers, so you saw from the previous slide, we're talking at around 50 to 55,000 cancers per year, and about 25,000 come from the through this symptomatic urgent pathway. Screen detected cancers accounting for between 17 to 19,000 cancers, and then the remainder coming from symptomatics. And then there'll be a proportion that don't fall into these three categories, and that will be women who present as an emergency with something else and their breast cancer is diagnosed incidentally, or if they present with metastatic disease at that time. So taking all of that into context, in March 2020, on March the 17th, there was a cascading of information that came down from Simon Stevens. And it was a letter that was sent to all the chief executives of the trust called Important and Urgent Next Steps on the NHS Response to COVID-19. And essentially what this letter did was instructed the trust very directly that they had to create capacity, both in inpatient and in critical care. And as a consultant, what that meant was that that information was then cascaded down through the medical hierarchy, and we were told to basically have a look at what we had planned over the next few weeks and work out what we could do and what we couldn't do. And all of this was against a background of a slightly odd situation, in that we were also told that we had to keep cancer services going. So on one hand, we had to prioritise who to operate on, but on the other hand, we were told to carry on business as normal, which clearly wasn't going to be possible. And at that time, no one really knew what was coming in terms of the pandemic and how much critical care capacity would be taken up. And to be clear, the reason that COVID-19 has such an impact on other services in the hospital is because of the staffing that is needed to look after patients in critical care. So what you end up with is a shortage of anaesthetists and nurses, which means that you then can't run elective services in theatres because you don't have the staff for it. And in some cases, it was also because physically you would need to create space for critical care patients in environments such as operating theatres. So all of this was being looked at by the trust as to how to manage things, and this was happening in every trust across the country. And then on March 23rd, as we all know, the national lockdown began, and at that point, most screening units, in fact all screening units, stopped sending out routine invitations for women to come forward for screening. And that was never mandated centrally that should happen, but clearly one of the aspects of the measures that were put into trust was to reduce footfall. And so we converted to remote working where it was possible, for example, in multidisciplinary team meetings. We converted as many of our consultations from face-to-face appointments to using either telemed. Video platforms were brought in to do consulting. And we also started assigning prioritisation scores to cancer. So there were two systems that were brought in. One was to assign a score to the severity of the cancer, and the other was to assign a score to the patient with regard to their perceived risk of COVID and what would happen if they contracted COVID, so taking into account their age and comorbidities. And the impact on referrals was sudden, and it was immediate, and in April 2020 there was an absolute cliff edge fall of the number of patients being referred from primary care into secondary care. And at the same time there were a lot of publications that were coming out which were predicting, based on modelling, that there was going to be an absolute disaster and another C crisis in cancer. So not just a COVID crisis, but a cancer crisis that would ensue. And I began to wonder what was the impact of the measures introduced to control the COVID-19 pandemic on breast cancer referrals and treatment, and how could we start looking at this in a way that had utility and that was real world. So the data set that we went to was the cancer waiting time data, and cancer waiting time data is publicly available. It's on, the link is at the bottom of the screen that you're looking at. And essentially there are targets that are around cancer activity and performance, and these are published on a monthly basis by NHS England, and what they tell us is the number of people who are referred into services, and the data is provided at trust level, and the number of patients who have undergone their first treatment for cancer. And the time lag is about 6 weeks. So the second Thursday of the month, the monthly data is presented, and on that second Thursday, it will be for the 2 months that preceded. So yesterday, for example, was the second Thursday of the month, and the December 2020 data was published. So this slide is showing you a month-by-month comparison of the volume of referrals between January 2019 and January 2020, going through over 12 months. So it's comparing 2019 to 2020, broken down by month, and also by the nature of the referral. So where the blue line in the middle is the total number of women who, or actually 5% of referrals are men, but the total number of people referred to secondary care for assessment of the suspected breast cancer or with breast symptoms. The orange line is the ones who are referred urgently, and the grey line are the patients who are referred with symptoms. So these are the ones where the GPs may not be so concerned. And what we also know from national data is the conversion rate of these referrals into a cancer diagnosis. And for the orange 2-week wait referrals, the conversion rate sits at around 5 to 5.5%. And for these symptomatic referrals, it's about 1%. So there's a big difference in the index of suspicion that these patients are referred with. And what you can see here, so with lockdown gets implemented, and as I said to you earlier, there was this absolute fall in the number of referrals, and this becomes very immediate because patients have to be seen within 2 weeks. So we saw it in the hospital that by the middle of April, we had the second week of April last year, we had almost no referrals coming through because people had just stopped going to general practitioners to be referred in. And it bottomed out in April, and then since then we've been witnessing a recovery. And what this graph, the data up to June 2020, we published in the British Journal of Cancer just towards the end of next year, and which suggested that there was a recovery coming. And then the data subsequent to that shows a steady increase in the number of referrals coming through. And what I think is clearly of interest is what's the impact of subsequent lockdowns. And it seems to be at the moment not very much. The business as usual, and these the message, the very strong messaging that has come out that the NHS is open for business seems to be getting through. And also clearly that there has been learning in both primary and secondary care about working in the confines of the pandemic and keeping patient flow going. So that's the referral data. And then looking at the first treatments. So again, a little bit of background, because I wouldn't like to presume that people know how we treat breast cancer specifically. But essentially, breast cancer, the approach to treating breast cancer is a multimodal approach made up of local and systemic treatments. And by local treatments, we offer surgery and radiotherapy. And our drug treatments, the systemic treatments, fall into 3 broad categories, of which we have hormonal therapy, which is drugs like tamoxifen, chemotherapy, and biological therapy. And in terms of sequencing of treatment, most commonly people will have an operation first, and then that will be followed by drug treatment and then radiotherapy. And sometimes there are good indications for giving chemotherapy up front, or indeed giving hormonal therapy up front. And how we decide who gets what and in what order is informed by tumour characteristics, patient age to a certain extent, comorbidities, and a process of shared decision making. And the kind of characteristics that will influence our discussions, we're looking at the size of the cancer, whether the local lymph nodes are involved, how aggressive the cancer is with regard to its grade, and its receptor profile, which gives an indication of the predictive response to treatment. So whether it's estrogen receptor positive, or whether there is a receptor expressing the septin receptor, and these determine the use of chemotherapy and biological therapy. And there were a lot of concerns raised about giving chemotherapy to patients during the pandemic. One of the main side effects of chemotherapy is immunosuppression, which will clearly make patients more vulnerable. But the use of systemic treatment for patients who have estrogen receptor positive cancer was a very useful approach, and a hierarchy of how we could prioritize our theatre time if it was going to be reduced included that we would prioritize the ER negative patients first, then the HER2 positive patients, and then by age. So you would operate then on premenopausal ER positive disease and then postmenopausal ER positive disease. And a directive came down from the Association of Breast Surgery that all cancers should be clipped, which means putting a little marker into them at the time of diagnosis, which means that you can then know where the cancer was, and then to start patients on endocrine therapy with a view to operating at a later stage. And that option is available to about 80% of breast cancer are hormone receptor positive. And as I showed you earlier, a third of breast cancer occurs in the women over the age of 70. ER positive disease becomes more common as women get older. And so this provided a way of offering treatment for breast cancer without and mitigating risk of the pandemic. And there will be arguments for a long time about whether this is optimal treatment, but it was a sensible decision to be made during the midst of a pandemic when resources arguably were going to be rationed. And then looking at how this reflected in the cancer waiting time data for first treatment. So first treatment is mandated to be given within 31 days of a diagnosis, and that's a government set target. And so if you look at the number of people who have received their first treatment for cancer, it is a proxy for the number of diagnoses that you get, because you have to clearly be diagnosed in order to receive treatment, and it will reflect activity broadly a month before in terms of referral activity. So what we see here is, so I've marked out again the timing of the two lockdowns. Again, we are comparing activity month by month from January 2019 to December 2020, comparing each month as it came. And this spike that we saw in March 2020 of the number of people who were receiving first treatment for cancer was an absolute reflection of pandemic planning, in that a lot of our patients, where possible and where appropriate, were started on hormonal therapy, therefore receiving their first treatment for cancer, and then with a view to operating on them lately. So people who were booked for surgery, planned surgery in April, were brought forward, so causing an inflation of the March figures. And then we see as the number of referrals and the number of cancers go down, the number of first treatments goes down. And what we're seeing here is that the recovery has taken a little bit longer. If we go back a couple of slides, we could see that with the referrals that they'd largely recovered by the autumn, by September. And for the treatments, we've now seen recovery in December 2020, so following it by a couple of months. And that would make sense in that you would have a slight lag in that process. It also suggests that we have developed systems to mitigate against the pandemic pressures through things like reconfiguration of services within hospitals, for using independent sector capacity. So for example, in Oxford, we have been providing NHS care in the local private hospital since March last year for breast cancer patients, some gynecological cancers, and also skin. And so there has been a use of capacity. And I think this also suggests that some of the concerns that have been raised about a backlog of undiagnosed, untreated cancer is slightly mitigated, and clearly further work is needed. But I think some of the trajectory of the recovery in itself is reassuring. And I just want to mention a little bit about screening. If you look at the total amount of first treatment work in 2020 compared to 2019, the overall shortfall is sitting at around 15%, between 15 to 20%. So the number of cancers treated is about 20% lower, 15 to 20% lower in 2020 compared to 2019. Screening for breast cancer was effectively suspended for about 3 months. So as I said, in March, most screening units suspended their invitations, and then the recovery started in May, and by September, all screening units were reissuing routine invitations. And what impact that will have on stage, presentation, whether, you know, those are longer term questions that we will need to answer. But some of the gap will be explained by the fact that screening was suspended, rather than, I think, a missing out on a lot of symptomatic disease that hasn't come forward. So to summarise, I think we can all agree that there was a significant impact of the measures to manage the COVID-19 pandemic on referral patterns, which was observed immediately after March 2020. I think we can also agree that the second lockdown in November 2020 has, at the moment, seemingly had a small effect on breast cancer referrals. We've recovered largely, the recovery has largely been observed for referrals by September 2020 and for first treatments by December 2020. And clearly the next question to ask is, what is the impact of the current lockdown that we're going through? And further work is needed to answer some of these questions about, has the effect been homogenous amongst different groups? So looking at things like age and ethnicity is certainly of interest, and deprivation. And these data are now becoming available through, again, publicly available data. So there is something called the COVID-19 Cancer Equity Pack, which is being produced by the National Cancer Registration and Analysis Service, and that is providing some information about individual patient characteristics and referral patterns, and also the Rapid Cancer Registration Dataset, which has been produced as a direct response to the pandemic, looking at patterns of treatment largely, also diagnoses, but also patterns of treatment. But both of these data sets have limitations in what they're looking at, but they're certainly of interest moving forward. There's a few people that I would like to acknowledge. So in the Nuffield Department of Population Health, Gillian Reeves, Isabel Barnes and David Dodwells. At St James University Hospital in Leeds, Karen Horgan and Emma McInnes, and at the Mid and South Essex NHS Foundation Trust, Jill Clayton, all of who have contributed to the work that you have seen and will be contributing to work going forward. Thank you very much.